The following podcast is part of a certified educational activity titled Marking New Milestones with Immunotherapy in Locally Advanced and Early Lung Cancer. Latest data informing best practices for multimodal management of stage 1 to 3 NSCLC with Drs. Jamie E. Chaft and Jonathan D. Spicer. Access the entire activity and complete the post-test at peerview.com/CBB860. Downloadable slides and practice aids are also available.
Good day, everyone, and thank you for joining us on this peer-review live event, Building on Progress, Marking New Milestones, the present and future of immunotherapy in locally advanced and early stage lung cancer. I'm Jamie Chaft. I'm a thoracic medical oncologist from Memorial Sloan Kettering Cancer Center in New York, and I'm honored today to be joined by Dr. Spicer from McGill up north. He is a thoracic surgeon and one of the leaders in multimodal therapy and research. So here we go, talking about expanding the benefits of immunotherapy from advanced to earlier stages of non-small cell lung cancer. Truly an exciting time. And we're going to start with a case, and throughout this discussion in the next hour, we'll go through a few cases, and you'll see how the data is evolving, as well as the complexities of medical decision-making in this setting. So here we are with a 65-year-old man, 30 pack years. He smoked, and he is appropriately referred for a screening chest CT, a practice we know that is not commonplace, at least in the United States.
Neither in Canada, actually.
Yep, so that's something we can all work on, right? So a CT-guided biopsy is ordered of the mass identified here in the right lung. We see a clinical T2 mass, as well as an N1 lymph node that's both hot by PET and positive by EBUS. So how do we handle such a patient, and is it any different now than it was? So I think to appropriately answer that question, what we do today and what we might do in a year, we have to think about the data that's come forth in the last perhaps 2 years about the evolving role of perioperative immunotherapy in patients with stages 1 through 3 non-small cell lung cancer. And the reality is the perioperative space is crowded. This is my research life, and it's increasingly crowded. There are multiple different trials in both the pre- and the postoperative settings, some of which are perioperative, and each of them is just subtly different. In the adjuvant space, we have 4 completely accrued trials. The Empower 010 study we just saw read out at ASCO, the Anvil study, BR31, and PEARLS, each answering very similar clinical questions of adjuvant, PD-1 or PD-L1 agents after chemotherapy. And then the neoadjuvant space is even more complex. We have Dr. Spicer, one of the leads of Checkmate 816, who will walk us through some of that recently resulted data. I had a big role in LCMC3, and we'll look at that briefly. And then we have Empower 030, Keynote 671, AEGEAN, and the ongoing Checkmate 77T. These latter studies are both pre- and post-operative therapy, and still yet to read out. So we have to think, what is the rationale for neoadjuvant immune checkpoint inhibitors, followed by complete surgical resection? And some will ask the question, do we need complete surgical resection after a neoadjuvant checkpoint inhibitor? It's interesting, what's the rationale for all perioperative therapy? To treat patients when they have a lower disease burden and an intact immune system, ideally to cure them, right? Neoadjuvant perhaps has the advantage of having the full tumor with its plethora of neoantigens in situ, rather than the postoperative setting when you're searching for those few remaining cells. It's absolutely true that neoadjuvant chemotherapy is better tolerated than adjuvant chemotherapy. The same we'll have to see for immunotherapy. And then, of course, we have the opportunity for surrogate endpoints at the time of surgery, as well as translational studies for biologic and immunologic correlates. So who gets what drug, and how do we pick the right target? And this too is increasingly complex. We have PD-L1. For those of us, such as myself, who are believers, we have tumor mutation burden. Perhaps there's something unique to the TILs. And then what about driver mutation? Does smoking status matter? Who do we give what drug to, and when? So this is a study near and dear to my heart. The Lung Cancer Mutation Study. The Lung Cancer Mutation Consortium is a group of academic institutions that has done a lot of work on oncogenes. Their most recently completed project was a very large study of neoadjuvant immunotherapy that we'll look at. And they're moving forward with the LCMC4 LEADERS study, which is really a large screening study looking to identify oncogenes prior to preoperative therapy, and then assigning genotype-directed therapy to patients with those oncogenes. It is a Herculean effort, really getting enough tissue and turning around the genomic testing in time to assign therapy in the setting of a clinical trial. It's been a long time getting it off the ground, but it's soon to launch. And even some of the therapeutic studies associated with this trial are currently enrolling. So this is perhaps the next generation of biomarker-matched precision perioperative therapy. However, this is data from ASCO as well as data recently published showing that we have a very tall bar to cross here. If we are looking to sequence all patients before surgery, we have to perhaps do better than we're even doing in advanced disease, where this testing is standard of care and the biomarker-directed therapy is standard of care. We saw the MyLung Consortium data at ASCO showing that it's only about half of non-squamous non-small cell lung cancer that's tested for EGFR, ALK, ROS, BRAF, and PD-L1. That's actually pretty sad, right? These are standard of care tests that lead to standard of care therapies. And across the United States, we're not doing it. I don't know, how are you guys doing in Canada? Probably better than we are.
Well, it's patchy. A lot of testing is heterogeneous, and there's a postal code effect up here as well, depending on where you're treated and where you get your tissue tested. It's something we're working on, having a more uniform approach, but it is a complicated task, no doubt, and early stage remains a bit of a gray zone of to what extent we test in which settings. But it depends on where you are, basically, is the answer.
And interestingly, in the early stage, there continue to be large geographic variations in genomic testing as well. And in the advanced stage, probably the commercial complexities are really what make it so spot-wise. There are so many different tests, and it depends on what vendor has gotten to what institution and created what contracts, and perhaps what kind of biopsy was done and how the tissue is utilized. It's all too common for us to see an extensive FISH panel, but no testing for EGFR, the far more common genomic aberration. And now, with an FDA-approved therapy for KRAS G12C, we have a whole other test to incorporate for those who were not getting NGS testing. So you see, both from the MyLung Consortium and from Flatiron EHR-derived data, we are not doing that well in terms of testing, and there might be some further disparities to who is tested and who's not. So we need to get this right in advanced disease, but I would argue we need to get it right in all lung cancer and apply those findings to the early stage as well. So I guess, we need to talk about this a little. What is it about preoperative chemoimmunotherapy or immunotherapy alone that we need to think about? From a surgeon's perspective, from an oncologist's perspective, I think there are different issues that come up. So from a surgeon's perspective, let me ask you, what is it you worry about it? What data do you want to see to make you think preoperative immunotherapy is the way to go?
Yeah, it's interesting. I've been bought into the concept of neoadjuvant therapy through my fellowship training, and it was sort of part of the philosophy with which I approach my practice. So you're sort of preaching to the converted, but I think when you look around, it's not a common approach. It's probably fewer than 5% of patients who would need indication for neoadjuvant conventional chemotherapy who will actually get it. And I think most surgeons around the world favor an adjuvant approach. It's in some ways more straightforward. There are fewer complexities to the preoperative investigations. We talked about getting the diagnosis, the testing, and all that. But I think for years now, a lot of surgeons have been concerned about how the treatment will impact the patient, their operability. People worry about progression on therapy, making someone who was resectable at presentation unresectable if they don't respond well. And that's understandable given the historical response rates to conventional chemo, but I think things have changed a lot and are changing very rapidly now. But I think those are the common concerns. And then there's no good data really about the influence of these novel therapies, immunotherapy in particular, on the operation itself and then the outcomes for the patient thereafter. And it just takes a couple of small papers, small series with some concerning results, or just some chatter in a conference room about a challenging case for a lot of rumor to create concern and fear, understandably, among surgeons, because these are usually not easy operations to begin with. So I think that has a lot to do with why the adoption has been patchy or slow, but I think we have some good data coming forward that will encourage folks.
So how long is too long for preoperative therapy? So say we're going to give a tyrosine kinase inhibitor with an 80% response rate in stage 4 disease. How long are you comfortable letting that patient wait before they get to the OR?
Well, so my thinking has always been that if a patient progresses, first of all, if we're talking about truly locally advanced disease, if the patient progresses on therapy, it's unfortunate for the patient, but it's a good thing that they didn't go ahead with an operation, because I generally think that patient is a very poor prognosis, and it's not having accelerated their time to the OR that we would have magically, prevented the brain metastasis or the bone metastasis that emerges later on. So, and that's well borne out by the oligometastatic data, where the benefits of local consolidation are most significant in people who respond to systemic therapy. So my thinking for locally advanced or early stage lung cancer is similar. And what experience I do have with targeted therapy preoperatively has all been off protocol and patients with large tumors. We had some situations emerge as a result of the pandemic where we couldn't get people to the operating room in due time. So ALK fused patient or EGFR mutated patient. And it's been those patients that we've treated that way I've found to be very rewarding, because usually there are excellent responses, maybe not complete pathological responses, but responses that are meaningful surgically, such that maybe a patient I might not have attempted by a minimally invasive approach, I'll treat with a VATS approach or something like that. So the duration, I think if you have the luxury of restaging, re-imaging the patient and reassuring yourself that there's good response, there's certainly diminishing returns over time, but I don't have a fixed prescribed time for what is too much neoadjuvant therapy. That's probably something we're still trying to figure out, right?
Yeah, it's interesting. It's one of these things our colleagues are starting to call oligoremnant disease. So perhaps not someone with purely locally advanced disease, but that patient of yours who had oligometastatic disease at the time of diagnosis, or a limited burden of disease and just has a lung tumor left and nothing else, and what should we do with that? That's perhaps the next generation of clinical trials.
Right.
Immunotherapy is interesting. We'll move on to some of the data. And we'll start by what was truly a window of opportunity study. And I've been a naysayer against window of opportunity studies historically, because this is a window of opportunity that perhaps if you've missed it, the patients might lose their surgical opportunity. And I see your point, and I agree with that if someone progresses within 2 months, they were likely to progress by the time they'd healed from their thoracotomy or their VATS. However, this study we were a little skeptical of. It was a study of 2 doses of neoadjuvant nivolumab, and it was a study in unselected patients. So just 2 doses, you could argue not many patients are going to progress in just 4 weeks of therapy, thankfully. However, they were unselected, and we knew at the time that at least in second-line advanced disease setting, that the objective response rate to single-agent nivolumab in unselected patients is less than 20%. So here we are giving a therapy to patients with potentially curable, potentially resectable disease that had less than a 20% chance statistically with all available data to work. And I think we saw the very surprising results that really fueled the neoadjuvant field for immunotherapy, in the sense that there might be something unique to this tumor microenvironment in the earliest stages of disease, such that the immune system is primed to respond. And we saw major pathologic responses in nearly half of the patients, complete pathologic responses in some of the patients. And this is after just 4 weeks of therapy. So it was definitely food for thought, and the numbers were far too small to draw any firm conclusions, but something that got us excited. So we moved on to the Lung Cancer Mutation Consortium's effort, and so instead of the 2 studies that conducted the nivolumab study, this was many large academic institutions that got together and ultimately enrolled a goal of 180 patients in the same clinical setting. So this was resectable stages 1B through resectable 3B in the 8th edition, with just 2 doses of atezo. Now, atezo is a 3-week drug, unlike Nivo, that was 2. So 6 weeks of therapy. And there were all sorts of really nice correlates built in here that to try to give us a sense of who responds, who doesn't, and what's actually going on in the body in response to immunotherapy. And I think we were humbled a bit here. And this is more along the lines of what we expected, that when you study a much larger group of patients, that the pathologic regression rates are less than we're seeing in the Nivo study. But still, 7% of patients had tumors that demonstrated a pathologic complete response, and about 20% a major pathologic response, which is defined as 10% or less viable tumor cells in the primary tumor. Now, this is also certainly intriguing, and I will argue it will be even more intriguing if we can figure out who those patients are that were able to benefit from immunotherapy in the absence of chemotherapy through all those fancy correlates. So we saw 2 studies subsequently that I think really got everyone excited about the paradigm of neoadjuvant immunotherapy. However, this is with chemotherapy, and arguably you're trying to cure these folks. You gotta, in some senses, throw the kitchen sink at them, particularly those with resectable stage 3. So this is the Nadim study out of Spain. It's been multiply presented, and I think every time the data looks just as good as it did the first time. But it was a study of 3 cycles of carboplatin and paclitaxel. And yes, I said carboplatin, not cisplatin, that drug that we have always been told is the level 1 evidence for perioperative therapy. However, we know that the majority of our patients cannot tolerate. So carbotaxol and nivolumab. And it was 3 cycles, not 4. 4 is the number, the magic number we've always considered for perioperative therapy, based on the empiric studies that are now nearly 15, 16 years old. Patients went to surgery, and there was adjuvant therapy in this study for what it's worth. And here we saw updated data in the publication of the progression-free survival. And it's a little busy. It's a lot of patients here, but you see some fairly impressive data in terms of progression-free survival. The little red arrows are the patients who have progressed, and you see that fortunately there are very few of them. But fascinatingly here, we saw 63% of patients with a pathologic complete response. I think none of us actually believed it. We wanted to, but we didn't. So the skepticism was well met, and we were very eager for the randomized data to bear out. Here are those same curves in the PFS and the OS in the modified intention to treat population. Certainly there's some censoring after 18 months, 2 years here. However, the data look pretty darn good for stage 3. Certainly far better than Pacific. Now that's an unfair comparison, but we have to keep that in mind when we get into discussing who should be considered for a surgical resection with stage 3 disease. And here's data out of Columbia, as well as some of the Boston hospitals participated in this study. Very similar to the Nadim study. However, they used nab-paclitaxel in this study and atezolizumab. Again, patients with 77% of them were clinical stage 3. And you see here a truly tremendous rate of major pathologic response, over half of patients. And the vast majority of patients had complete resections. That was 87% here. You can keep that number in mind when we start to think about larger populations in the Checkmate 816 data. But overall, a truly impressive outcome for a majority very high-risk population. And I'll wrap up here by showing you the data of the ongoing phase, or not the data, the schemas of the ongoing phase 3 neoadjuvant studies. We mentioned these earlier on in what was the crowded space, But we truly see here a commitment, a very big commitment to the neoadjuvant space of chemo-IO. These are all randomized studies. The vast majority of them have adjuvant components, and they have various endpoints, which interestingly, some of these have been updated since creation of these data to path-CR. We saw so many pathologic complete responses in 816 that the bar has really moved, and we've seen a redefinition of our potential surrogates. So many patients have been enrolled, many more to enroll. And with that, I'm going to pass this off to Dr. Spicer to go over what's the truly exciting Checkmate 816 data.
Thanks, Dr. Schaff. So I think that was a really awesome review of what's going on, which I agree is a really exciting time to be treating patients with operable disease. And I was fortunate to be a participant in this study, which we opened back in 2017. It was originally designed comparing actually nivolumab plus ipilimumab to a platinum doublet. But then in response to the chemo-nivo results of the NADIM trial, the company moved towards implementing a chemo-immunotherapy arm, and that's what ended up becoming the phase 3 study that we have presented at AACR and now more recently at ASCO. And so eventually we recruited about 380 patients who were randomized to nivo chemotherapy versus chemotherapy, each for 3 cycles. And as you can see, the baseline characteristics for these patients are fairly consistent in what one might expect for an operable stage, the old 1B to 3A by AJCC 7 staging. Patients had to be ECOG PS 0 to 1 and considered obviously operable by the multidisciplinary team. Primary outcome measures were event-free survival, and as originally designed, again, as Dr. Schaff mentioned, the second independent primary outcome was major pathological response, but through an amendment that was updated to pathological complete response. All right. So as we said, these were the treatment allocations and adverse events that we saw from the treatments. And what was surprising again is that despite the addition of immunotherapy, there wasn't really a substantial increase in the toxicity of the treatment or patients coming off treatment due to the addition of nivolumab. And we'll go through the surgical data in a little bit more detail in a moment. But again, there was a comparable cancellation of surgery, a little bit less in the nivo chemo arm, about 16% of patients having surgery canceled versus the chemotherapy group where there was 21% that did not make it onto surgery. And the majority of those who didn't make it onto surgery were for real-world scenarios, patients who did not have adequate pulmonary function, declined to go on to surgery, those sorts of reasons. And there were only about 4% of the patients in the nivo chemo arm that actually progressed by RECIST criteria versus 6% in the chemotherapy arm. So progression on therapy, at least radiographic progression, is an unusual event, even with conventional treatments. The real stunner was the PCR rate, and again, a little bit humbling in comparison to what we might have expected from the NADIM data, but this is blinded independent review, and I think a very strict and rigorous definition of complete pathological response, where we're talking about not only the primary tumor bed, but also all the dissected lymph nodes. Nonetheless, the difference is striking, with about an odds ratio of 13.9, 12-fold increase, or over 12-fold increase in the path-CR rate, 24% on an intent to treat basis versus the chemo cohort, where only 4 out of the 179 treated patients had a complete pathological response. And we know that this is a strict reporting of PCR, because what we might have expected historically from chemo is closer to 5%, 5 to 7% from older trials. So we know that this is a pretty rigorous assessment of path-CR. In the patients who underwent resection, we're talking about a 30% rate of path-CR. which is again not quite as much as the Nadim trial, but a very significant amount of patients. That means close to a third of patients did not have any residual tumor, and that's food for thought moving forward. When we looked at reasons for or subgroup analysis to perhaps improve selection for future design, there wasn't really anything that jumped out. It's important to say that EGFR and ALK were tested for, and these patients were excluded. So this is unlike, for example, Empower 010 in the adjuvant setting, where that was not an exclusion criteria. So this is a little bit, I think it is an important selection metric for a neoadjuvant chemo IO study. But despite that, based on stage, histological subtype, or even PD-L1 expression, there was no group that was clearly not benefiting from the chemo-nivo combination, at least as far as PCR is concerned. The MPR rate, as one might expect, was also strikingly different, so no surprises there. And I think this is where I'm blown away. Is the depth of the pathological response is not is very significant. So even in patients who may not have achieved an MPR or a PCR, the median viable tumor cells in the chemo-nivo group was 10% versus 74% in the chemo-treated cohort. If we make a bold assumption that tumor kill in the peripheral disseminated metastatic, micrometastatic cells is equivalent to what's going on at the primary tumor and lymph node, we are obviously very hopeful that the long-term oncologic outcomes will follow along, given the high efficacy of this treatment in this context. The treatment did not seem to be, efficacy didn't seem to be stage specific at all, even though the numbers are low in the 1B cohort. There's consistent value from a pathological response perspective across stages. And obviously as a surgeon, this is the meat for us. There was a high number of thoracotomies, but this is a global study with over 150 sites around the world participating. And there were community hospitals as well as academic hospitals. So I think that's very important for the external validation of these results as they might get taken up around the world. With 2/3 of the patients having a thoracotomy, but it's important to remember this is complex disease. We had a lot of advanced cancers. More patients in the chemo-nivo arm were able to have a minimally invasive approach, especially in the 3A cohort. And there were more conversions in the chemo-treated patients, almost twice as many conversions from a minimally invasive to open. Again, suggesting that perhaps the operations were more easy as a result of the chemoimmunotherapy treatment. I think this is incredibly important. The more patients were able to undergo a lobectomy in the chemo-nivo arm than in the pneumonectomy cohort. We know the ills of pneumonectomy. It's a disease unto itself. And so the fact that at least numerically fewer were performed in the chemo-nivo arm is very encouraging. From an adverse event standpoint, there was no striking difference between the two cohorts, except perhaps higher rates of pain in the chemo-treated group. And this is likely attributable to the fact that there were more thoracotomies, more conversions, which would stand to reason that this would lead to more pain. So going back to our case, and this is an interesting patient with a difficult and unfortunately positioned lesion rate. If you look at the infused CT, you can see it's encasing the ongoing PA to the lower lobe. It's touching the upper lobe, it's touching the middle lobe, it's going into the lower lobe. I think in most surgeons' practice, this is a patient, at least up front, who would be booked for a pneumonectomy or at least an attempt at sparing some lung, but it might be challenging. So what do you think, Dr. Shaft? How would you guys approach this patient?
Yeah, so it's interesting. This patient is one I would have concerns about, about induction therapy if he was having any hemoptysis, just based on the relationship to the vessels. But if this patient were clinically stable and you're really thinking, can you get away with a sleeve? Is it going to be a pneumonectomy? Can I shrink this? and what kind of fibrosis is going to be associated. This is like the exact patient that since the Nadim data was presented a few years ago, I've been saying in the clinic, I would, if I could, give you chemo IO. Where we are today, it's a clinical study, and it sounds like the patient would be a great clinical study candidate.
Yeah, and in fact, that's what we did, you know. And one of the challenges from a surgeon's perspective now with the blinded trials is that we don't know what they got. And so unless they develop some immune-related complication, like become hypothyroid on treatment, we don't really have a guess. And that's going to be really good for the data, but it leads to some really tough decisions in the OR. And just before I operated on this patient, about a month prior, I had another patient who had a similar tumor on the left side, and it was just inseparable from the ongoing PA. It was right in the fissure. I tried as I could to try and do a sleeve or something. It was impossible, and I ended up doing a left pneumonectomy on the poor guy. He did okay, but I felt like a criminal afterwards because he had 1% residual tumor cells. So it is a frustrating thing not knowing how to predict who has had a complete response or not, and it makes the decisions in the operating room quite challenging. So for him, we ended up doing a relatively complicated angioplasty, bronchoplasty, sleeve sort of situation to preserve a bit of the upper lobe. He ended up doing okay, but it really, we're struggling in the OR, I find, not so much technically. This is a difficult operation regardless of what you do to him preoperatively, but with the decision making, what to compromise on margins versus or preserving lung. So we're learning.
And certainly we know that our data has not consistently shown us that radiographic and pathologic responses mesh. So this case, he doesn't look like he's had a great response radiographically. I guess you just don't know what you're going to get into in the OR.
That's right. That's right. And here we see, you know, the path that's showing a histiocytic response, and there's no tumor cells. So it's great for him. And I'm glad we were able to save some lung, but it could have easily gone the other way, where there's significant residual tumor and, in fact, you know, positive margins, which has a whole set of consequences.
So we didn't have all the information going in for this patient, right? We would have wanted to know, do they have an oncogene? And perhaps, what's the PD-L1? So back to my advocating for getting all the information up front on everyone to help us appropriately allocate our patients to good recommendations of pre versus post-operative therapy and what kind. So let's change up the case a little. Ooh, this is ugly. Tell me about it.
So this patient, you know, we have all sorts of issues with the pandemic, getting people through all of their preoperative testing in due time. I think from an equity perspective, Canada's a nice place, although there are inequities still, especially in the space of testing, as we talked about. But we do struggle getting all our testing done in an adequate amount of time. And although this patient presented with a PET scan showing a fairly localized tumor, yes, it's locally advanced, but would have been a great scenario to give induction. But we obviously have to stage the patient. The EBUS gets done, and a week later, this patient comes to the emergency room with a fever, very high white blood cell count in the 20s, and this very ugly situation that's emerged in the right upper lobe with a nasty post-obstructive pneumonia.
So I tell you, I'm not going to give them chemo because they'll get post-obstructive infection. What do you do next?
Yeah, so this is a scenario where we didn't have much of a choice but to operate on her. So, you know, these scenarios will emerge regardless of our valiant attempts to give neoadjuvant therapy to people. Hemoptysis and post-obstructive infections, I think, are the most common reasons in my practice where a patient who is clearly a candidate for neoadjuvant therapy will not do it for I think clear reasons. But so I think that's the importance of having these adjuvant trials coming up and having other options for these patients when neoadjuvant is not an option.
And can you cut this out by VATS? It's a big tumor.
Yeah. So no, I did not operate on this patient by VATS. I would be very impressed to see someone try, but in my hands, anyways, that wouldn't have been a safe thing. And I think the discussion of VATS versus open is a very important one. And Dr. Kim and the team in the UK who ran the Violet trial did an amazing job of doing a very scientific and rigorous comparison of VATS versus open, and presented this data, the 1-year outcomes at ASCO. It was a great presentation, and really I have to commend them for doing such a rigorous prospective randomized surgical study that they're hard to come by in our specialty. And what was clear is that the minor adverse events were fewer in the VATS cohort. There was less pain, more quick return to normal physical function, fewer serious adverse events, post-discharge, better quality of life, and an amazing impact in terms of cost effectiveness. VATS is far more cost effective than open surgery, especially when you look at a longer trajectory over that year after the operation. So there's no doubt that when feasible, VATS or an MIS approach, minimally invasive surgical approach, is preferable. But I think it's important to remember that the short-term outcomes of death or postoperative death or major complications was really no different between the two groups. And an open operation is not a catastrophe. I think at the end of the day, doing the safe operation in that surgeon's hands and the best oncologic surgery that surgeon can offer, regardless of access, is at the end of the day the most important thing. So I try not to get too obsessed about the length of the incision and try and do the right thing. So I think it's more dangerous to attempt something by minimally invasive approach that shouldn't be, or that one doesn't have the experience to do. That can have much more devastating consequences than erring towards opening when one is uncomfortable. So that's my take on the Violet data. But I think the other piece of information that came out in the last month or two was the results of the JCOG trial that the Japanese Cooperative Oncology Group ran, comparing segmentectomy to lobectomy for stage 1. And I know we're talking about locally advanced disease here, but this was food for thought for me. None of the periadjuvant trials that we've talked about allowed for segmentectomy, and this is including the adjuvant trials. They insist on a lobectomy with a complete resection. But if we look to the breast oncology literature of the last 30 or 40 years, where we've gone to great lengths to reduce the impact of the surgery and preserve the organ, for me it seems only reasonable that we would do the same for lung, especially when segmentectomy was found to be superior to lobectomy from an overall survival standpoint. And this is despite a higher local recurrence rate. So clearly there's something to the idea of saving the lung. And if you pair that data with what we saw in Checkmate 816, where it seemed that there were fewer patients requiring a pneumonectomy for an equivalent number of R0 resections, I think that neoadjuvant regimens need to push our surgical teams towards doing less and less invasive, less and less extensive surgery, because this is probably not only going to have a long-term oncologic impact, but it stands to reason that the quality of life of the patients and the survivability of their treatments will be improved as a result of doing that. So we do need to look to better, shorter endpoints that aren't just about the cancer, but also the experience of the operation.
Yeah, I think we're really going to have to dive into that data into a little more detail and think about how many of those lesions were solid, how many were ground glass, what were the SUVs, what were the histologies, and see if we can identify an appropriate population that requires lobectomy to prevent local recurrence and re-op and issues like that.
You're right.
I think,
if I may, I think the devil is the details, because people will be tempted to compare across trials. And if you look at LCMC3, I was noticing in the fine print that T4 lesions invading the mediastinum weren't allowed to be included that's not a feature of 816, and that for sure can influence in a big way the R0 rates. So, I think that we need to, you're right, we need to look at this much more closely and think carefully about the design of these future trials. How are we going to take a close look at these other endpoints and manage them?
So I think what we've come to with that case of yours is the realization that many of our patients are they're just not going to be appropriate for neoadjuvant chemotherapy. Either they're too sick, they need to get that tumor out for complicating factors, or they're upstaged at surgery. And I think all too often we see these clinical T1 tumors that are N2, despite completely resected. And that's why, despite my love of neoadjuvant therapy, these ongoing adjuvant studies are truly important too. And it was pretty exciting at ASCO to finally see the data of one of these. So here you see a list of the ongoing adjuvant studies. We went over them at the very beginning. There are also some combination studies which are likely going to have to be modified, at least in the US, based on the Empower data that was presented and we're about to go over. I can say I've had a primary research interest in the perioperative space my entire career, and we've had nothing change until this year, and now we have ADAURA and here atezolizumab. So this is a well-designed study of classically indicated adjuvant therapy. So this is 7th edition, stage 1B greater than 4 centimeters through 3A, included N2 disease if it was completely resected. Patients got standard of care cisplatin-based chemotherapy. So in my clinic, that's about 20% of patients I see who are fit for cisplatin. But so a highly selected patient population, likely younger for that reason. And after chemotherapy, they were enrolled before, however, they had to be without progression after and randomized to atezolizumab for a year or best supportive care. And this is a study that had a primary endpoint of DFS. The study has a rather complex design where they hierarchically test endpoints, but this is the first. And this is DFS in stages 2 and 3 in the PD-L1 positive population. And here you see a hazard ratio of 0.66 and a highly significant p-value. A nice splitting of those curves. Of course, a lot of censoring, as this was a very early readout. However, this data is more than a year after completion of therapy, and clearly those curves are apart and they're staying apart. This is the subset analysis of all PD-L1 positive, and really interestingly, not a whole lot falls out in terms of who benefits and who doesn't. Of course, the molecular subgroups are as expected, but kind of crossing unity, not totally no benefit. Here we see the DFS in all randomized patients. This is all randomized stage 2 and 3, so irrespective of PD-L1 expression. And again, a hazard ratio of 0.79 and statistically significant. One can start to argue if a hazard ratio of 0.79 is meaningful in this setting. And clearly, when you see this, you want to start looking at subsets to see if you can figure out who within the overall population is benefiting. However, an overall positive analysis. And the subsets here, I think, are as expected. The PD-L1 negative patient tumors did not benefit. This was done with the SP263 after the well-known issues of the antibody that was originally used. And you can truly see a tremendous benefit in patients whose tumors were PD-L1 high, and a modest benefit in all comers whose tumors are, or a good benefit, hazard ratio of 0.66, all comers whose tumors are PD-L1 positive. However, absolutely no benefit in tumors that are PD-L1 negative. So there remains a big unmet need population. But one would imagine this is going to be very soon a new standard of care. So we're back to our patient. This is a patient who undergoes a thoracotomy. As Dr. Spicer has told us, this is not a VATSable tumor. Even a robot wouldn't help you there, right?
No.
Complex resection. It's an R0 resection, but unfortunately P2, N2, completely resected. So I guess the big discussion point is, what do we need to know? I would argue we need to know EGFR at a minimum and PD-L1.
Yeah, I agree. we're fortunate. Our pathologists have been very good about testing these patients. So now anyone with a stage 2 or higher tumor will get NGS in our environment, and the multifocal stage 1s. But I agree with you. That's at a minimum that needs to be sorted out with what we know about ADARA and now the benefits of adjuvant immunotherapy. These are the patients that we're so happy to have this new option for. And as you mentioned, the incidental and node positive patients that I think will continue to come through our hands inevitably, despite our best efforts to screen those out beforehand.
So PD-L1's 1%, KRAS G12V. What adjuvant therapy do we give? This patient needs the kitchen sink. I think we don't yet know if adjuvant atezolizumab truly has benefit in PD-L1 1%. However, such a high-risk tumor, adjuvant cisplatin-based chemotherapy, if fit for it, and then likely a year of adjuvant atezolizumab. Now, the radiotherapy can be debated. LungArt did not show an obvious benefit of postoperative radiotherapy for N2 disease. However, the study was not done using modern radiation techniques, and I think, at least in my institution, the jury's still out about the role of PORT.
Yeah, I was curious. What say a case like this obviously it's stage 3B disease. What would you advocate for postoperative RT in this patient, and how would you sequence it? Or...
Yeah, if there's multifocal nodal disease, I think we would certainly refer for a consultation. We would consult with the surgeon about their concerns about dehiscence of the complex operative repair. But with multifocal nodal disease, it's really a risk-benefit analysis. We don't know yet. In LungArt, they covered a station above where the known disease was, which is not standard of care, and they weren't using IMRT, so the heart doses were presumably much higher than we would see with modern techniques. So I think the jury's still out, but I fear we'll never really get that answer. I don't know who's going to, perhaps proton therapy will be the way to go.
Fair enough. Yeah. It's amazing how these trials can be the start or the stop of a therapy that may have had benefit in selected folks. And
and the endpoint of the study wasn't, I would argue, is not ideal at a landmark, not truly a Kaplan-Meier analysis. However, so let's just sum up resectable disease. I think we have no data to guide neoadjuvant versus adjuvant, although certainly we're excited about the potential superiority of immunotherapy in the pre-op setting. And from that data we just looked at, adjuvant immunotherapy is likely to become standard of care in patients whose tumors are PD-L1 positive. So finally, increasing cure rates, we hope.
Yeah, well, I think all your work in this area is paying off. And we're thankful as surgeons because it makes everything that we do more valuable, I think.
All right, now we move on to controversy, right? So what do we do with N2 disease? We just started to talk a little bit about it, but here's a case of a T1 N2 adeno positive by EBUS. And really,
well, actually, I put this case forward for a couple reasons. For the obvious controversy about stage 3A, but there's also the challenge of even making the diagnosis of 3A with this AP window node. We see it time and again with the left upper lobe lesions and a hot AP window node, and any of the trials would ask us to get tissue on this, but then that's another operation, which you're not going to resect just to get them on a neoadjuvant. So they're hard patients to get on trial, not to even start on the controversies, but that's what we're here for, I guess, is the controversy.
But then you send them to me, and I look at AP window nodes, and I say, well, that makes your radiation field much larger, and it increases the heart dose, so can't you cut it out?
Well, I'd love to send you more of my patients, then.
So let's talk about stage 3. Really, this is where we come in, and the radiation oncologist. It's really a multimodal, multidisciplinary patient assessment, and I think we have to think about everything, right? Heart function, performance status, weight loss, and then the tumor. How big are the nodes? Can the surgeon cut them out? And like I just said, how big is the radiation field, and what are the consequences of that going to be, the pneumonitis? And I also think, how big is the tumor, and is it going to be radiosensitive? If it's 9 centimeters, I worry that radiation is really just not going to do the trick, and I think we need more data there. But it's certainly a medical concern. This is an exceptionally complicated slide, and I think we're not going to dive into it in detail, but it will be available in your slide sets for reference. It's a good one, and I think we need to really dive into patient characteristics and think about what can be done and can we get it all out. Certainly, if you're choosing an operative approach, I think the first and foremost question is, can you get it all out? And Checkmate 816 changes that a little, right? Because you're seeing surgeries that are less than were anticipated. And that's not something we've really ever seen before. We always said the surgery needed is the surgery needed. However, maybe we're gonna have to start thinking more about what it could be.
Yeah, I think what this slide really tells us is you need that team discussion for these patients, because I don't know that I disagree with anything that's in here, but what might suit one center may not suit another for a variety of reasons. And it's not necessarily to the detriment of the patient that every hospital will deal with this, or every team will deal with a particular patient differently. But all this is moving so quickly and moving targets. And you're right. I think that the basic point is that stage for stage, people aren't all the same. Stage 3 is not a stage 3 from one case to the next.
So let's talk about that person that we really can't resect. And I will remind the listeners that Pacific was not necessarily that. There are patients who were treated on Pacific, as I'm sure you all know, which is chemoradiotherapy followed by durvalumab, who in many institutions would have been offered a surgical approach. So this was stages 3A and B, 7th edition. And this was the updated 5-year OS that we saw at ASCO. And I hope that we don't see a 6-year and a 7-year, because what you see here is that we've hit a plateau. And that is quite reassuring that, at least in the next slide, you'll see the progression-free survival data. But it does seem like we've hit a plateau. And I think the plateau is higher than I would have expected. Which is quite reassuring. Remember, these are patients who had not progressed after chemoradiotherapy, so it is a hand-selected population. But the DERV is doing something. In about 10% of people, it's probably curing them. And you'll see the progression-free survival data here, which is more of a plateau than the OS. So I would argue by the progression-free survival data that we can confidently at this point quote patients that would have met criteria for this study, a 33% cure rate, 1 in 3. And I think 1 in 3 is far better than our staging analyses suggest, which is closer to 1 in 4 or 1 in 5, if you look at the stage-based survival curve. So hopefully we're curing people. Are you ready to tell your patient that while you can't resect them, they can still be cured?
Absolutely. Yeah, no, this was a game changer when it came out, and continues to be. My opinion is that if we had just done a stage 3 study, best local therapy followed by adjuvant IO, we would have been able to bring adjuvant therapy to surgical patients much sooner. But obviously I understand why studies aren't designed that way. But this is hugely important. And I do think they're cured. I on the flip side, I agree with you. I think operability and the definitions in a trial like this are always going to be a bit controversial. And I always hear that multi-station N2 is inoperable, but it's not. It's very much so operable. They have less good prognosis overall, but it doesn't mean they're inoperable. And I think that eventually we will, now that IO is going to become part of the local therapy options for stage 3 patients, I think we'll be in a position to conduct a second go at the Albane study. Maybe, we'll see.
You mean how to deal with this patient? The borderline operable patient, what do we do?
This patient, I remember because we discussed at our tumor board right around the time that Pacific came out. And before Pacific, maybe we would have offered this patient an intrapericardial pneumonectomy, or this is a complicated, high-risk operation if you're going to offer it. And I think the nice thing about Pacific is that I like to do these operations, but the outcomes aren't always the best. And I feel lucky now that we can offer these patients something that is less risky, offers a very good long-term and QOL perspective outcomes option. So I'm thankful for that. And even though that this patient was physiologically, technically operable, I think they were much better served by chemo RT and Durva.
Yeah, I mean, interestingly, we still see a lot of patients who ultimately fail in the lung and the lymph nodes, right? So while we're giving effective systemic therapy, we see lower rates across the board, but lower rates of brain metastases and distant metastases. We really have to get back to answering that question of who would be now that everyone will be getting immunotherapy in some form, who will be optimally managed locally by surgery? Because we've gotten the systemic part down now. Now we have other questions to ask, and none of those are directly being asked, but here are all of the studies that are ongoing, and you can see the whole. If only we had this many Pacific Oceans, there are lots and lots of Pacific studies going on. We saw updates at ASCO from Keynote 799, which showed concurrent pembro with chemo was certainly well tolerated in this non-randomized study with various different chemo options, cispam or carbotaxol, and certainly many other updates on concurrent radiotherapy and immunotherapy, which are likely to be kind of moved forward as we see have been done in the resectable space.
I think, if I may, one of the flip sides, although I'm very happy to be able to refer a patient like that to chemo RT after having evaluated their operability and having a good look at them. On the flip side, I've noticed far more patients in my practice emerging after 6 months, a year of adjuvant IO after chemo RT, now with progressive disease. And let me tell you, these are nightmares of operations to deal with. And I'm unfortunately seeing that in people who are 50, 60 years old, who we do go on to resect after all this. So they were obviously operable, and it's suboptimal scenarios. So I think it's really important to have those discussions up front and have a good assessment, especially now that we have all this information that we can add to the operation that's helpful.
We have just a few minutes left. I want to try to address some of the questions that have come in from the audience throughout our babbling discussion. I think we talked a lot about the relevance of PD-L1. So I'll ask you as the surgeon the second question here. So what if someone has an excellent response to induction chemoradiotherapy? Do you think we could be giving them immunotherapy alone? I'm sorry, chemoimmunotherapy. Can we be giving them immunotherapy alone? Do they need the chemo?
Yeah, I think the question of are we curing with systemic therapy alone is one that we have to address now. There's nearly a third of the patients who are operated who may not have needed it. We need to accurately predict when that's occurred. And we need to be able to predict that to be able to design those trials safely, comparing observation to surgical resection or some other local therapy form. But that time has come. I think if you look at the Albane trial, the PCR rate in the resected population was about 50%, and people will say that there was equivalent to OS. So we're near that at least PCR rate. Radiation always muddies the waters of what PCR would translate to OS, but yeah, I think we have to ask the question and try and answer it formally.
And I'll conclude just by addressing the third question here. It's all about biomarkers. There's nothing about lung cancer that isn't about biomarkers. So we need to test for them all quickly and as early as possible in the cancer care. Increasingly, we'll see the relevance in the early stage. And I'd like to thank you, Dr. Spicer, for joining me today, and thank the audience for your kind attention. And thanks again for joining us.
Thank you.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post test for instant credit at peerview.com CBB 860. This activity is supported through educational grants from Bristol Myers Squibb and Merck & Company Incorporated.